another mic, another presenter mic. Okay, good. It has to be.
I won't.
Yeah.
Okay, good afternoon. Sorry for the delay. So we have the presentation on statin in the shadow of CKD being presented by Dr. Malcolm. Our sponsors for today are AstraZeneca. We hope it will be educational to all of us and we may grasp something out of it. Thank you.
Okay. Good afternoon, everyone. Let's just get this set up. Is that okay? I did that. That's okay?
We have a small problem again.
With the... It's now not fully zoomed up. This thing can be really finicky. Eh?
Sorry, no, you can hear everything you say.
Understood, yeah. Perfect. That's okay. That's the slide size. Good. Oh, so it will be on that side? Okay.
Oh, yeah, it's actually the other side. Yeah, that works. That works.
Okay, good. So we'll be talking about statins in the shadow of CKD. I think we're all aware of the use of statins in our patients. So it's just that I picked this select group of patients because we don't usually talk about patients who have CKD and those on dialysis usually. So as an introduction, we need to know that cardiovascular disease is a major cause of morbidity and mortality in renal patients, and in any patient for that matter. It's in CKD patients, it's even worse. It is for this reason, there is a 10 to 30 times higher general population risk for the same gender and age and race for a cardiovascular mortality. And that's why the AHA has put into effect that we have the CKD patients to be placed in the highest risk category, and therefore they would really need the statin therapy, because dyslipidemia on its own is not the only risk factor they have in CKD. There's issues to do with proteinuria, there's chronic inflammation, there's the issues around calcium and phosphate dysregulation and the calcium vascularization as such. Next, we look into the way CKD will also impair the lipid metabolism and some of the common features that we have because of impairment of ApoA1 and LCAT, which are the enzymes that really work within lipid metabolism. We have an increase in triglycerides due to impaired clearance. There is increase in the small dense LDL, which is the one which is mostly atherogenic in this situation. And because of those impaired enzymes as well, there is an issue with HDL reduction. And that's our so-called normal or good cholesterol, isn't it? So in the other situations, we have this diagram just showing us how mortality risk increases over time in patients with CVD, cardiovascular disease in chronic kidney disease. The normal risk factors are in all our patients that we have. You can see there's issues around hyperglycemia, hypertension, dyslipidemia, there's the inflammation. Now this is what is more towards chronic kidney disease. So proteinuria, genetic components, vascular calcification, endothelial dysfunction, and chronic inflammation is the increased risk above what you can see in the green, which is for the normal population. So this just basically shows you how their high-risk individuals become when they have cardiovascular disease with dyslipidemia. So what do you expect with the abnormalities in CKD? As we've said, there is a hypertriglyceridemia, mostly because there's impaired triglyceride clearance. There is a reduction in HDL, sorry, which is your good, so-called good cholesterol, because of reduction in ApoA1 and LCAT activity, which actually now reduce the amount of HDL and actually makes the HDL that is existing to be not as active, or it's impaired. It's not a good quality HDL. And HDL's whole function is to actually transfer back cholesterol to the liver for it to be recycled. In that respect, the LDL goes on being created without any stops, and that's how they are small. The ones that we can't really look for, which are more atherogenic, is these small, dense LDLs, which are now prone to more oxidation and more oxidative stress, and that's what gives you now the cardiovascular disease. Okay? Next, we have the HDL itself. What is it involved in? This is the reverse transport of cholesterol from the vessels in the peripheral vasculature back to the liver for it now to be recycled. And this is the issue. Without that function, then the LDL, which is being transferred and put into the tissues and into the peripheral vasculature, is now more prone to oxidation. The other causes of the HDL, as we have seen, is because we have reduction in the ApoA1 and the LCAT main enzymes activities in the lipid metabolism that we will discuss, and then because of that, there's now promoting excess LDL oxidation. And in the LDL, we don't only see it increased in nephrotic syndrome. It's usually typically elevated in nephrotic syndrome, not really that much in patients with CKD and those with dialysis. And the qualitative high levels of IDL and SDL, this is the small dense lipoprotein. This small dense LDL is not really something that we can quantify, but they're the ones which are more atherogenic and they're more prone to oxidation as well. So this decrease in LDL catabolism increases their circulation time plus their oxidation, which now gives you how we can look at it in this diagram. Is LDL and all cholesterol as such comes from the two main pathways. There's an endogenous pathway and an exogenous pathway. The exogenous is what you take in, so that's through the intestine, goes through the chylomicrons to the liver. And on the other hand, the endogenous effect, they will produce LPA, and endogenous will produce the VLDL, which is then converted by the LPL enzymes to LDL, which takes the cholesterol now to the peripheral vasculature. This is where your HDL picks up that excess cholesterol and then shunts it back to the liver for it to be dealt with. But now what we end up with in CKD is injury or activity decrease of the main enzymes like LCAT, LPL, and CETP, which now makes triglycerides go up. The HDL is not there to mop up the LDL and the cholesterol, so the LDL goes up and oxidation of those cholesterol remains, and the HDL itself is impaired in its function as well as its amount. So this diagram also summarizes the same as to how the precursors of HDL are now affected and how LDL itself just continues to grow and deposit into the peripheral vasculature. So there is an interesting part of CKD that is not really talked about, which is the paradox and reverse epigenetics, or reverse epidemiology that's seen in CKD. So not necessarily seeing low LDL and low cholesterol levels in a CKD patient makes you happy, okay? In a CKD patient, seeing low levels of cholesterol is not necessarily a good thing. Why? Because those cholesterol, it is now, according to the CHOICE study, we had evidence showing that low cholesterol levels in CKD and dialysis patients actually means that they may be having chronic inflammation and they may be having actually poor nutrition. So it's a reverse epidemiology that not only will you see good levels of cholesterol in a CKD patient or a dialysis patient, and then you say, okay, everything is going well. And this just shows you how it's absent in the lower, you have less cholesterol levels as the ages go up, and yet there's still a problem with having nutritional deficiencies as well as chronic inflammation in those patients. So when should you measure the lipids? LDL and total cholesterol may appear normal in CKD, but the atherogenic forms that we've discussed, like the small dense LDL, are not really something that you can detect in the labs. So it's still worth getting a baseline lipid profile on all the patients who are in CKD or on dialysis, okay? And this is the evidence towards it, showing that there is grade 1C on adults newly identified with CKD to get tested for their lipid profile. So what about the role of statins in dialysis, in CKD, but not dialysis patients? That means pretty much everyone else. So CKD1, where your GFR is above 90, all the way down to CKD4, where you're just above 30. So in these patients, what we are looking at here is that adults above the age of 50 with a GFR more than 60 should receive a statin, okay? Those who are above 50 with a GFR less than 50, then they should have a statin with ezetimibe combination, okay? So it basically means that if you look at what they're saying, it immediately puts you in a higher intensity risk group, and that's how your statin increment will be given in terms of how you'll give the statins, okay? And this is the KDIGO guidelines based on how we will actually give statins in these patients. The main things to worry about is the age of 50 is where you would look at giving a statin to all your patients as such. So if they're above the age of 50 with a GFR above 60, then you just start them on a statin. If the GFR is below 60, then you start with an ezetimibe, which means you're just adding double therapy to the statins. And on this study, I know it's a lot, but I just want us to figure out the statins used in moderate CKD, they use the effect of pravastatin on cardiovascular events, and what we have to look at is it just reduces the cardiovascular event down here. We look at the vascular event rates in people with the risk of coronary artery disease and concomitant CKD. Basically, it reduces your risk when you're on a statin. They just use pravastatin in this group. In the SHARP study done by Colin et al., they basically looked at simvastatin and an ezetimibe, so dual therapy against placebo, and you can see basically all the things that they tested for were having very good outcome reports, okay? And that's looking at your MACE in terms of coronary events, CVDs and stroke, along with acute myocardial infarction. So what about the use of statins in CKD and the older population? So this is a March 2025 study released in the Lancet, and it basically looked at a group of people that are usually excluded from all studies, above the age of 75 all the way to above even the age of 85, and patients who are CKD and who had chronic kidney disease, okay? So in this group, basically, even the older you got, it still had significantly reduced CVD incidences and mortality for patients who are even above the age of 75, and this even significantly decreased the CVD incidences and mortality in the ones even older than 85. So they didn't find that there was the risk and the worry that we would have is that if you give them another drug, they're going to have myopathies and the adverse effects from the statin, nothing was found to be significant in that area. So given that the conclusion of the study basically looked at saying, listen, if in this age group it actually does show some benefit, so you have to consider it in patients, but you have to look at a case-by-case basis to make sure that there are no drug-drug interactions, and it's a discussion between you as a provider and your patient as a person to receive the drugs. And this is the study that we've just discussed, which was released now in March 2025 in the Lancet. So how about statins in the dialysis patients? So this is another group of people where we don't really know what's going on for them, how should we treat them? And given that we look at now the major other problems that dialysis brings up, where we've discussed the chronic inflammation, the vascular calcifications, the proteinuria, these are other risk factors that give you a problem with your cholesterol not being the only risk factor for cardiovascular disease. And therefore, in the dialysis patients, the results are a bit less positive, okay? So in the studies that were done in the 4D, Aurora, and the SHARP studies, which included the dialysis patients, they basically did not find a significant reduction in cardiovascular events in these patients. So basically, you can see when the patients were on the statin, if they were not on dialysis, there was good effect. But if they were on dialysis, there was no change in the cardiovascular risk and disease study. As well as in the Aurora study, there was reduction in the lipid profiles, but the cardiovascular death risk did not change at the end of the study. As well as in the SHARP study, we find that patients on hemodialysis didn't really find much of a benefit. It's almost at the baseline, okay? And lastly, we deal with patients who are now transitioned. So they were on dialysis and now they get a transplant. So what happens to them? In the adult transplant recipients, the suggestion is go back and start giving them the statin because they're still back at the high cardiovascular risk that they would have. And the evidence for the statin use is through the ALERT trial, which showed that this drug, fluvastatin, was used in that one, and it reduced the 3-point MACE issues of myocardial infarctions and cardiac death, okay? So the KDIGO guideline then took up on this and suggested that statins can be used and should be used in patients who are post-transplant. So the next thing to think about is which statin should I really give to a patient? And this is based on a number of things. So you have to individualize the treatment, you have to look at the cardiovascular risk profile, LDL levels, the age and the comorbidities, if they have diabetes, if there are potential drug side effects or there are interactions, then if there is any patient preference or adherence, and if there's cost issues as well, and also if there's specific populations that you look at, like HIV and the use of pitavastatin. And then when we see the dosages, so to start off in dialysis patients and CKD patients, it's a baseline 20 to 40 milligrams in terms of atorvastatin, or 5 to 10 milligrams in terms of rosuvastatin, which puts you in the mid-intensity groups immediately. On dialysis patients, because of what we have discussed in the different trials, KDIGO is a bit more reserved. So they tell you, if a patient has been on a statin, don't stop it, but you're not routinely going to start it on the patient because it may not make a difference until we have more data that may suggest otherwise. But in the transplant patient, you then re-monitor them for their cardiovascular risk and then get them back onto statins. This table, which we can read at a later time, basically gives you the different dosages that you could start on patients who are with a GFR of 3A to GFR of 5, stage 5, grade 5 of, so basically if you're below the GFR of 60, then you can see the dosages don't really change excessively. They go down to the mid-intensity range. So lastly, what else is out there? There are newer options, which is the PCSK9 inhibitors. This is an exciting bunch of drugs which they're going to look at into, which will be injectable, and the frequency of medication will be less. And this is going to be used right now. They've shown the research is very positive on patients who have been on statin therapy, and then they add the PCSK9 inhibitors, and they really achieve good LDL goals. So it may really benefit our high-risk CKD patients who have multiple comorbidities as well. And the newer agents have different trials, which you can see how the LDL target really drops nicely, and using these monoclonal antibodies, there's a very good drop in the cholesterol levels. When we look at the study which has been done, AstraZeneca, which is actually who's supporting us today, is at the forefront of this, giving us this new drug, AZD0780, which again is exciting. It was launched and published at the same time in the JACC, again 31st of March this year. So this is very relevant and very new. And it's a new late-breaking clinical trial presented at the ACC and published simultaneously in the JACC, showing benefit of this investigational medicine on top of standard dose of care. So in summary, CKD patients are at high risk of cardiovascular events. The statins improve our outcomes in non-dialysis patients. Dialysis patients, the benefits are unclear, but you do not stop the statins. They are still safe to use. And in patients where the individualized health decision is being made, you do it within those patients who are on dialysis, CKD, and transplant patients. Those are the ones where you're looking at high risk, and those are the ones that you want them to be on statins. And then if you're in doubt at any time, just get one of the nephrologists to take a look at the patient and give you a way forward on which way to go in terms of the lipid profile and treatment. Okay, thank you very much. Any questions? Questions? Yeah, sure.
You showed a graph about statins in CKD dialysis patients, right? And you say that there's no significant difference between mortality. Is it all-cause mortality or cardiac events?
So cardiac events. So CVD risk. So this is specifically into CVD risk.
Okay.
Yeah.
And,
so looking at the MACE, basically myocardial infarction, cardiac death, stroke. Yeah.
So is it a reduction? Is it the no difference in events, or is it no difference in mortality?
In mortality.
Mortality.
Yeah.
So events.
Same, both. There was no difference in the events or the cardiovascular mortality. That's why it's murky. You don't stop the drug, but you know it's may not entirely prevent anything from happening. Yeah, go ahead.
How expensive is the PCSK9 inhibitor?
So this is brand new and super expensive. I mean, and any monoclonal antibody for that matter at this point is expensive. So that's why it's being used as add-on therapy. Hopefully, as more is added on, then the price comes down, and as the patent also expires, then somewhere in the corner somewhere we'll make something cheaper. And then it'll be more affordable to use, because the benefit of a PCSK also is the way you drop the amount of drug usage. I mean, you just knock off the tablets in most cases, and this thing works in shots, one injection over a duration of time. Sure, go ahead.
Now, while following up these patients with dyslipidemias, while following up on these patients with dyslipidemias, just generally, we usually do liver function tests and creatinine kinase. but in one of the slides, one of the studies among the elderlies, it was noted that there was no significant myopathies or liver dysfunction. So should we keep on like doing LFTs for these patients to see if at all maybe the statins are causing maybe liver issues or muscle issues in?
Yeah, thanks. Thank you for that question. So looking at in terms of following up on statin use, in the initial phase when starting up statins, you need to see that, if it's going to cause any myopathy or if it's causing liver dysfunction. As time goes by, it becomes less of an important thing to look through unless you're doing routine monitoring. But if you're targeting it as directly associated with the statin, then there's no data to suggest that you should routinely do it aiming that the statin is causing this. Unless you're looking at somebody who has sudden issues with liver dysfunction and myopathy, then you'll follow it up to see whether the statin is the one which is causing it. Yeah. But in the initial phase when you start up, yeah, definitely. Because we'll start up even, it depends on the intensity of your statin as well. If you start a high intensity statin and then somebody comes in immediately saying, oh, there's pain in my muscles and all this, then you are at complete liberty to follow it up. And then I think one of the slides somewhere along the line also shows the benefit of coenzyme Q10 on that, which improves muscle lessening of the muscle myopathies. So you could aim for even combinations with coenzyme Q10 when you find somebody who has those things. Okay? Good? Right. Any more questions? Excellent. Thank you.
Hand of applause for Dr. Malcolm.
Thank you.
Thank you. So next, I'd like to present our sponsor for the day, AstraZeneca.